Can you hear us from Lincoln?
Yes, we can.
Thank you. Just load this. I hope you can see my screen there. Austin?
See the screen, but not the webcam.
They can't see you. They can see
Okay,
you.
that's fine. That's okay. My name is Khalid Mahdi. For those who haven't met me before, I'm one of the nephrologists at Lincoln. In class today, we're teaching you the whole of nephrology in an hour, probably under an hour. My best. So it's about glomerulonephritis today. And first, before I start, do you really think it's important that you learn about glomerulonephritis?
Yes.
Probably know the next question. Why?
Early in our case.
Yeah, good, excellent from clinical practice point of view. Excellent. So you need to know about it enough to enable you to recognize this deviations, whether that's in clinic or mainly in the emergency department or assessment unit. Any other reason to learn about glomerulonephritis?
One of the causes of it. I want to go in.
Yes,
So the complications are bad.
that's right. So it's important to learn because it's a serious disease, and if you don't recognize it early, it can have serious implications. So again, it's about recognizing the cases with glomerulonephritis. Any other reason to learn about?
Specific therapies.
I guess you might come across some patients coming to you with complicated treatment or depression wider in it.
It's common and prevalent.
It's not very common. It's not very common. But yes, going back into point, early recognition is important.
Yeah.
I think that would definitely be number one. Any other reason?
Can happen in adult.
Yes, so you need to think about it in terms of what system. If you're doing MRCPs,
Yes.
how
Yes.
often do you get,
So
you
many
get asked?
Yes.
about it?
Yes. It's a favorite.
So it's, I guess, not the main reason, but that's an important reason we learn about glomerulonephritis. I don't think you're going to be asked about detailed management of IgA nephropathy, membranous nephropathy.
Yeah.
And third reason, I think that's going to be a reason any of. Yeah. Okay. And usual, fine. So we start. So we'll try and talk about glomerulonephritis. It's a big topic, and you've probably answered some of these. Why do you need to know about glomerulonephritis? Because you need to be able to say, could this be GN? If so, what pattern of GN is it? Because yes, you might tell him a GN, but if you know to be able to understand the significance of this finding, probably then into pictures or presentations. I don't expect you in AU to make a diagnosis. I don't expect myself to go to NAU and make a diagnosis there. So please find a diagnosis is not easy. All about recognizing patterns. I put this into nephrotic, that's right. I say this is nephrotic.
It's like there's something overlapping.
That's right. So you need to try and be able just to put them in this pattern. Then you only from there you can start making a list of differential diagnoses. And I said, getting a final diagnosis in most cases require a kidney biopsy. It's something you're going to find in you're going to do in your practice. Yes. Early recognition, early referral, having an idea of what could this be. Yes, and then to plan your initial tests when you see them. So if you try and put this into objectives, exactly being able to identify patients, being able to recognize patterns, and being able to describe how you manage them when you see them initially. So we'll try and talk quickly about the background and presentations, and then we'll talk about specific conditions. And we have a summary at the end. So when I say glomerular disease, what comes to mind first? Anywhere, any.
Filtration is affected.
Yeah.
So
Is it glomerular? That's right. What does the glomerular do apart from filtering things out?
absorption as well, but that's
Filtering, they're getting rid of, actually, they're getting all things go through that filter and then get absorbed.
Yeah.
What else do they do apart from
Separation.
filtering? They don't keep things in.
yeah.
Yeah.
Proteins.
That's right. So there's no
Barrier.
That's right. So if you're going to try this, you hit the glomerulus. Therefore, you may have issues filtering. You may also have issues with keeping the blood and protein inside.
Yeah.
So typically, when we say glomerulitis, we talk about blood and protein. And sometimes we say and more. Most of the times together. Certain condition where you may find one. So proteinuria or hematuria, in most cases both. And as a definition, well, I need to say that although we talk about glomerular diseases here, it's a broad term. It includes glomerulitis, but there are other conditions that can affect the glomeruli. Thin membrane disease. These are all diseases that hit the glomeruli, but they're not glomerulitis. So it's a wide range of conditions. It's not just one. You can't really put them together and say this is how we manage them or this is how we investigate them. But they share one thing, that there's disruption of the glomerular basement membrane. They will have hematuria or proteinuria or both, with some impairment of excretory renal function. If you just take this message out of this teaching, I think that's the most important. So proteinuria, what is proteinuria then? What's the normal protein excretion? Say that's normal.
Less than 0.3 grams in 24 hours.
Less than that. Say in terms of what we measure, when we talk ACR, yes.
Correct.
In terms of 24 hours, you talk about not more than 150. But then, if we talk about different grades of proteinuria, it starts from microalbuminuria, and that's an ACR of 3 to 30. Any ACR above 30, that's no longer micro, so it now becomes proteinuria, and that's equivalent to about PCR of 50. So that's called non-nephrotic or subnephrotic proteinuria. Then you've got nephrotic range proteinuria that's above 3.5 or above 30. And when you do a dipstick test and you find protein that's gone beyond micro, they have got proteinuria. So this is most likely above an ACR of 30 if you can detect it by dipstick test. What about hematuria? How do we define hematuria?
Micro and macro.
Basically, divide it into micro and macro. Good start.
Visible to naked eyes and not
Visible hematuria.
That's right. So either visible or non-visible. Visible is obvious. See from the urine. What's non-visible? What class as non-visible?
That's seen in my.
Yes, one thing is microscopic is two red blood cells.
Fragmented.
Or a simpler test that you do in the ward.
Dips.
A dipstick test. And 1+ is enough to say this is hematuria. But you need to confirm it. So normally, if we talk about persistent hematuria, you need to test. Particularly in GP land, when you do a test, it might be UTI, it might be for anything. So ideally, you need to say this is persistent. But yes, by definition, it's 1+ is enough, or 2 red blood cells, high power field. So in general, I think when you're assessing patients with glomerular diseases, just as a guide, you should have some focus of your clinical assessment. You want to assess them to try and look for any symptoms of glomerular diseases. There are not many, as far as I said, many. And I mean by that, maybe visible hematuria, proteinuria. They don't normally have a lot of symptoms. particularly related to the glomerular disease. But they could have associated conditions. So look for what system disease. RPGN, vasculitis. Most of the glomerulitis can be linked with other conditions. Not a direct cause, but they say that minimal change is more likely to be. Think about these conditions. And then part of your assessment will be to assess the renal function, whether that's clinically, by looking for symptoms and signs of uremia, fluid overload, that's through your blood test. Blood pressure is an important part of your assessment for potential. And then think about how much include the potential. I think this will become more clear as we go along. And in terms of assessment, essentially most patients, or all patients, really need renal function tests and urine dilistic test. That's a minimum. There are other tests that we need for most cases, but not all. Not everybody needs a kidney biopsy, and not everybody needs autoimmune screen. So far? Okay, so try and talk about patterns then of glomerular diseases. And this is a busy slide. I think it will be the base of discussion. The next few slides. So, I like to classify it this way. I know the one that we're more familiar with are nephrotic, I guess, and maybe RPGN. There's a big group called asymptomatic. You tend not to see them. We see a lot. These are the patients with either isolated proteinuria or isolated hematuria or both. They normally get sent to the GP because they don't have any other symptoms, they don't have any problem. Just found them to have proteinuria and hematuria. We'll cover each one in turn. So these are the main groups we're going to be talking about. So if we start with the asymptomatic, that is either hematuria or proteinuria. And undoubtedly most of my new referrals are coming to my clinic because of this. Do they all have GM? They do not. Proteinuria is a common reason for referral to nephrology. It can be diabetes, hypertension, heart failure. There's a long list of things that can be linked to stroke. You need to be able to identify which one is more likely to be GN, which one isn't. And some of the features that you look out for, it's more likely to be GN if you've got heavy proteinuria. So it's only got nephrotic proteinuria. Sorry, you can't see it, say this is hypertension. If they have got hematuria and proteinuria, particularly have casts, that's more suggestive of GN. And if they've got impaired renal function. Although again, that can be another condition. If you look at these, they're more likely to point towards GN. On the other hand, there are lots of things that can give you proteinuria, like decision nephritis is not GN, but it can cause a bit of overflow proteinuria.
A lot of protein.
Sorry?
Bodybuilders?
Is that like a renal threshold? Is there a renal threshold for protein?
So you got to have a lot of protein of something.
Yeah.
And that's why it's overflow. So you filter it, but you can't absorb it.
Yeah.
So myeloma.
Ah.
Yes. So when you do myeloma, you do check not the dipstick test when you do urine protein creatinine ratio.
That's Jones.
Yes. So there's protein creatinine ratio test with it. Therefore, if you check urine PCR patients with myeloma, come back very high. If you do urine ACR,
Yes.
it's not ugly, it's actually a bad protein.
Yes.
And you won't detect it in the dipstick test. You do protein creatinine ratio, if you do 24 protein collection, urine for 24 protein is very high. That's because of myeloma, for example, high proteins. Also, static, actually, you're familiar with static proteinuria, why we ask people to do tests. Stand up for a long period of time, you may have some protein. Functional secretory, functional heart failure, if you've got high venous pressure, you may have it. It's usually not significant, not a lot of proteinuria. Tumors, of course, proteinuria, UTIs, anything between 0.15, which is normal, to 2, can be any of these things. It can also be pneumonia. Okay, so but more likely GN, hypertonuria combined with hematuria, or if you've got casts. So if we start talking about asymptomatic non-nephrotic proteinuria, I want you to look at the whole diagram. It points to the same fact we talked about. When do you investigate and how you investigate? So if you've got normal GFR, probably need to repeat and check again, see if it gets significant proteinuria, which is early morning sample, and reassess. While on the other hand, we've got the third kidney option, there's more reason to look for GN. Asymptomatic microscopic hematuria. So it can be because of GN or non-GN causes. Just need to keep that in mind when you see this. So look for symptoms of this group. I guess to suggest these. And when you investigate them, I think GN is still less common than other conditions in general. And that's particularly relevant when you see people for the first time with isolated hematuria. If they're above 40, the first test you do is actually urology.
Cystoscopy.
That's right. So you need ultrasound scan, cystoscopy. If they are younger or if they have renal impairment, hypertension, proteinuria associated with it, and think, oh, this sounds more like urology rather than. Yeah, so it's more likely to be renal if you've got proteinuria, dysmorphic red blood cells, your cast, and low GFR.
Sorry, I don't get the significance of the cost. I don't get the significance of the cost to be indicating of glomerular disease.
So the cast is red cells and a protein.
Okay. It's technically not only hematuria, right?
Sorry?
So it's not only hematuria. If it is a cast, it has protein in it.
Yeah, so most of the time this is a relation with glomerular.
Okay.
That's when you see casts.
Okay.
On the other hand, if you see clots, there might be different
It's
Mhm.
down.
from lower down. So we move on to the next group, which is the macroscopic hematuria, and I think it's simple and more straightforward. This particular group, this is more likely to be pulmonary, more about malignancies. But it could also be GN, and the one that caused this particular feature will be IgA nephropathy.
Mm.
So they may present with visible. Yeah, slightly different. I said you don't know, and it's more of a painless and small urine rather than a bright head. Nephrotic syndrome, I guess that's the one probably more familiar with. So the definition of it kind of changed gradually. It keeps going. It used to be triad, now pentad, 5 things you need to look for, but you don't need all of them to diagnose it. So you probably just need the first 3 to say this is nephrotic syndrome. Causes. Now this one I can't really blame anything else. It's the kidneys.
Minimal change.
That's right. So most of the time it's caused by glomerulitis, and these are the common causes of syndrome, minimal change, membranous FSGS, and be caused by other conditions, other glomerulitis, but it won't be the first presentation. So IgA nephropathy, you probably hear this a lot because it's the commonest. That present in many ways, but one of them. And it depends which one of these depends on the patient's condition. So I can't see a patient in the assessment and say, oh, you've got FSGS. Say this is likely to be based on certain factors. Again, when we talk about it, probably pick up why I would say this man may have FSGS, not me. But I can never be sure without a biopsy. And then diabetic nephropathy is not glomerulitis, but they can present with nephrotic syndrome and amyloidosis. So this might help. Say, if you see a child we're almost certain this is minimal change. We don't biopsy them. It's by far the commonest cause of nephrotic syndrome. They normally start them on treatment without the biopsy, without histology. FSGS seem to be more common in Afro-Caribbean as a cause, as a leading cause of nephrotic syndrome, post-membranous nephropathy. So the percentage membranous nephropathy is more common in whites. With FSGS only just behind it. But change still actually common if you see in young adults. On the other hand, other conditions like MPGN are very uncommon. So evaluation along the same lines, you need to try and assess the renal function, assess the fluid status. You somebody with nephrotic syndrome. They got any edema, but also part of the fluid status. Blood pressure is part of that assessment. You need to look for associated conditions, and we'll come to that when we talk about them in details. Not all of them require kidney biopsy, but the majority do. The exception to that is children. That's it. Children have made a change. Everybody else. So things keep changing. Keep it for now. Everybody else in the biopsy. There's a new antibodies that we found for membranous nephropathy, for example. Now check later on. And when we started using it first, the guidance was even if you find you still do biopsy, shifting slowly towards if you find it very sensitive, very specific, why do a biopsy? So then we move to nephritic syndrome, which is the difference between nephritic and nephrotic syndrome. You've got hematuria in this one. With casts, you have polyuria. Polyuria is not necessarily above the 3 grams. It can be anything, usually less than the 3 grams that you find. But the main feature, I think, with this, I would probably say fluid retention and hypertension within both kidney function. We don't normally see hypertension, for example, with nephrotic. We see more proteinuria with less with nephrotic. Not very common. The classic example for it is post-infectious GM. Most cases, certainly. So evidence for glomerular inflammation, that's through proteinuria and hematuria with fluid retention and hypertension. So causes, post-infection is the commonest, but it can be also attributed to SLE, IgA nephropathy, and present with nephritic syndrome. From this, but it's the same method of assessment. When you see them, you've got to focus in mind. I've seen this person. I think it's what do I need to do? Function fluid status and look for any associated symptoms of other diseases that can be linked to it. In this example, ASO teacher look for sore throat, history of infection, skin infection, throat infection. Renal biopsy is always indicated, but yes, the exception, if you know somebody's got sore throat, you can prove that they have throat infection, positive ASOT, they've got clinical features. Other features to look for would be consumption of complements. Without it, I can't call this post-infectious GN. So you find below C3. RPGN, not common, very important to recognize, very important to act. Just because of the first word is graphics. Don't think that early. You've got AKI, and the longer you without treatment, the less likely you can kidney. So typically, renal failure over a period of weeks or days. The proteinuria, but very rarely. Unlike nephrotic syndrome, the main feature isn't fluid retention. So you don't have edema, necessarily have polyuria or hypertension. They are similar in a way, they are acute, but retention isn't the main. And the main feature histologically when you do a biopsy is finding crescent. Again, a long list, but on the top of them is vasculitis. See again, good basture, it's important to recognize it because out of the two, the vasculitis and good basture, the one that's more likely to cause damage, more likely to be irreversible, likely to be very rapid. Post-infectious GM can also present with RPGM. The IgA popping up again here, so it can present in different ways. The main feature, I said, is the biopsy finding of crescentic glomerulonephritis. That's when we say this is RPGM. Probably get bored, but important to look for multisystem disease, autoimmune disease, features of vasculitis. If somebody presents to you with this, they tend to have some symptoms like before being tired, not eating, in addition to the feature that we're more familiar with, skin rash, red eyes, ectasis, coming up blood, sinuses, sinusitis, hearing problem. Look out for features of vasculitis when you see. If you do a urine dipstick at the beginning, patient with AKI and it doesn't show blood and protein, don't have any of these. So they do need renal biopsy in the majority of cases. Sometimes if they are sick and you think it's going to take you 2 or 3 days to organize a biopsy, they can't wait. Sometimes we have biopsy. Then the last group, which again an outpatient kind of referral, although you sometimes see them presenting through the emergency admission unit with advanced CKD. That we haven't picked up before. Done some blood tests that you have 900 and you do an ultrasound scan and you find small kidney. If something has happened over a long period of time, most of the time for the chronic low grade GM. And if you talk about IgA, the IgA will be the commonest for this. Because they don't have symptoms. If there's no reason for them to have a blood test, it won't be picked up. And it tends to affect younger populations, so there's no reason for them really to have regular blood. Go and have a test for anything they find very high level. We have seen a few practice coming through any an MAU this way. Can you prove it? Most of the time, actually, you can't because kidneys are too small and biopsy would be too risky. But you assume it's likely to be IgA. Any questions so far?
I have 2 questions. The first one about the AKI, because that's most of the patients I see. Is there anything to worry me of a renal cause for AKI rather than the finding of proteinuria and hematuria in the urine?
So renal cause is a big term.
I mean, glomerular GN cause of AKI, yeah.
So when you see them first, you can't really tell.
Yeah.
Unless they've got vasculitis, they may give you history.
Yeah.
To suggest to you that. Symptoms, I said, not common. Mentioned hematuria, you know what you urine.
Yeah.
Dipstick test is helpful in the amounts.
Yeah.
So if you've got anyone with AKI, I think it's for blood and protein.
Yeah.
Put that out of your way.
Yeah.
It's definitely not GM.
And the TIN, is that among the entity we are discussing today, or that's separate?
No, that's it. We can talk about it, but TIN won't necessarily find.
Okay.
You may find some proteinuria, you may not.
Yeah.
So think about it. I want to exclude the AKI, I want to exclude my prerenal and posterior, and I'm left
Sure,
with
yeah.
intrinsic renal disease.
Yeah.
Then in this group of intrinsic renal disease, could this be GM or TIN?
Yeah. Because I'm asking because there is a patient, so I saw a few months ago in the ward and treated for AKI, and he was receiving the regular treatment for AKI, which is the fluids, and If I recall right, he didn't have any abnormality within his urine dip. And then because he wasn't improving, the consultant took history from him from the very beginning. And then we figured out that he was taking ibuprofen regularly 3 times a day for 3 months for treatment of rheumatoid arthritis. And the shift of the treatment was towards the TIN rather than pre-renal causes. So it's only the history here that's why I'm asking. Is there any way to figure out this earlier? Just
Yeah, so if they're not behaving the way you expect them to behave, I think it's
Yeah.
safe.
yeah.
So I always take a history of vomiting with a pinch of salt. Somebody tells you I vomited a couple of times last week.
Mm-hmm.
Can't use it as a feeling in AKI.
Exactly. Yes. Yeah.
If somebody's young, the 20s or in the 30s, and coming with really severe AKI, had diarrhea for 2 days, then this can't
Yeah.
just be
Not
dehydration.
matching. Yeah.
And if they're not behaving the way you expect them to behave, fair them.
Mhm.
That's one of the criteria.
Yeah.
If you've got AKI 1 or 2 who's not improving with the nephrology, of course,
Yeah.
they may need a biopsy.
Okay. Yeah.
Even if I can't find anything in the history to tell me it's TIN, I have to go and look for it.
Mm-hmm.
Again, extremely important. The same principle: rule out and treat, I guess, pre-renal, post-renal, and if they don't behave the way they should, look for
Great.
disease. Or of course, if you've got any clues from the start, this sounds more like TN, or they have blood and protein from the start.
Yeah. Great.
Dr. Mahdi, I have to see Dr. Morgan at 4 o'clock. If that's okay. I'll
Yes,
finish
okay.
everything.
So I'll try and make this quick, but we're still going to cover these conditions with a bit of information about each one of the commonest ones. But we start with some cases. I'll let you read this. Any question from Boston? What else would you like to know about this patient?
Drugs that he's on.
We want more information about what you mentioned.
Yeah.
I suppose that is
Quantification
nephrotic range,
of
at least.
And what's the kidney function?
Yeah, what was the baseline? Yeah.
Anything else?
History. So does he have symptoms or anything else? So I know he's got ulcerative colitis and hypertension, but is he vomiting? Is he coughing up blood, or is he?
I mean, you take a normal history with more focus on. I want to know what drug you take. For the kidney function, you look for AKI, dehydration, or what else?
Yeah.
Anything else you want to know?
Apart from your history.
So we get the fluid status, we get the bloods, we get.
Okay, so we send
Examination.
assess the fluid status, we assess the blood pressure, and we will assess the kidney function and the blood. Lipstick test.
Oh,
Yeah, I thought it was
I
already
thought we
done.
already
but
got it. Heavy proteinuria in urine dipstick.
Micro urine routine.
Does it really tell you has he got hematuria?
Doesn't mention about hematuria.
So yeah, you want dipstick test to tell whether they got hematuria and proteinuria because it makes a difference. You don't see hematuria with minimal change, for example. But you also want to quantify the proteinuria. You want the information about the kidney function. That's what we've got.
More than nephrotic type picture.
Yes. What do you call it?
Nephrotic
This is nephrotic syndrome.
Right.
Because there's a term we use quite a lot in nephrology. We say nephrotic proteinuria.
Yeah.
We use it a lot, but that's when we can't find the rest of the triad to say.
Yeah.
This man has.
Edema has got
That's right. So this
Albumin, etc.
So this man does have nephrotic syndrome.
Yeah.
Yeah, normal scan. So his kidneys look normal on the scan.
Yeah.
Doesn't tell you a lot about their function. Is this consistent with GN?
And like a membranous picture. Or...
Sorry. It's just a simple question. Is it consistent with GN?
I would say yes.
For that protein in the urine.
Yeah.
So the start, good start. There might be other differentials, but when you see that combined with the nephrotic proteinuria, it's got to be GN. I think they shouldn't have blood.
Blood.
So you kind of narrow that list, so you will have many things sound more like GN.
Yeah.
At the first start, you start big. Is it GN? No, well, fine. Forget all this complicated disease and think about something else. Is it GN? Can I put it into one of these 6 pictures, 6 classes?
Yes.
So we already know that GN sounds more like nephrotic. I've already narrowed your differential automatically. We said, well, nephrotic, what is the commonest cause of nephrotic syndrome? Membranous minimal change.
FSGS.
Yes. There are other uncommon ones in IgA. Start with big ones. So if I say, we've already said which clinical pattern does it fit in? The next question.
Membrane.
So clinical pattern is nephrotic.
Nephrotic.
Yes,
Okay.
so the big pattern is nephrotic. Differential diagnosis.
Is what we just said.
Listed.
Yeah,
Yes.
yeah.
If I'm going to list them in order, which one do you think I'll put first?
Membrane.
Membranous.
Yes, I'm not going to put minimal change.
Yeah, he's 56.
That's right. If I just look at the age and the person present to me, then it sounds more like membranous. It could be any. What about the mass in the lung? Has that got anything to do with this?
Often lung cancer is associated with membranous glomerular.
That's right. So cancers in general, not just lung cancer,
Okay.
malignancies in general are more likely associated with membranous
Membranous,
nephropathy.
Okay.
So membranous nephropathy, it's commonest cause of Tourette syndrome in adults. It can be primary or secondary. Primary means for idiopathic, that's immunological mediated. When I'm talking about untreated 10 years, I'm talking more about primary. So it's about renal survival 50 to 70% in 10 years, which isn't too bad compared to the others.
Yeah.
Why? Because a lot of them actually go into remission. Even without treatment. So majority of them are idiopathic, but we have to look for causes. Like most of the GNs, primary and secondary. Find secondary, you treat the cause, they get better. Really important to screen for causes. Secondary GN. Malignancy will be top of the list when we see them. SLE, yes, they can present with membranous picture on the biopsy plus some drugs. So diagnosis, from the presentation, you can tell kidney biopsy is important. Having added PLA2R, but PLA2R is now definitely part of our investigation strategy when we think somebody may have membranous. However, it's not positive in secondary.
Oh,
So in this case, it's probably going to come back negative anyway. And this just to talk about the progression. As you can see, by 5 years, those start with Tourette syndrome have more than 50% of them in partial remission. That's without treatment. Yes, under 40% are still nephrotic, and about 30% have complete remission. 5 years down the line, not given them any specific treatment. And that's part of the dilemma when we manage nephrotic
Membranous.
nephropathy. Because the treatment is heavy immunosuppression. So I know they're all going to have kidney failure and give them all the treatment. I don't know, I can't justify giving them strong immunosuppression while actually 1/3 of them will get better anyway. I won't talk a lot about the management, but in general, it's based on conservative management at the start. You give them about 6 months period of blood pressure control, ACE inhibitors, statins, and see if they move that nephrotic to as it might do. That's why we did 6 months.
Reasonable.
Yeah. So give them time, they may get better. By the end of 6 months, they're just getting worse, or even by 3 months, if they're clearly getting worse, you start treatment. By 6 months, they're still nephrotic, you start treatment. FSGS is a leading cause in Africa, Caribbean, and the second cause of nephrotic syndrome in children. Typically, when we treat children for renal chain disease, and they don't get better, we go biopsy. Yeah, it's mildly FSGS. The treatment actually is similar, but it's prolonged. So as opposed to respond to the short course of steroids, they tend to be longer course. It needs like earlier. Still, they don't always respond. And its prognosis is worse when you look at, if you compare this with membranous nephropathy. About 50% of patients will end up on dialysis in 5 to 10 years. And spontaneous remission is very rare, so less than 5%. Again, primary and secondary, so always look for a cause for it. Some of the secondary forms of FSGS are linked to what we call hyperfiltration. So obesity is one of the causes of FSGS. Simply, kidneys can't cope with the amount of work, so they start scarring, resulting in nephrotic syndrome and kidney loss. The same theory goes to when we say nephron loss. So patients who have surgery to remove and develop both and secondary. Children who are born with less nephrons, so premature babies, likely to have FSGS. So presentation with asymptomatic proteinuria is not common. Most of the time they present with full-blown nephrotic syndrome. And to diagnose it, you need a kidney biopsy. But again, there are a group of patients where I would probably say maybe I won't necessarily do one. Morbidly obese, and no other reason to think about any other conditions. A biopsy is going to be quite challenging. I do sometimes say, well, this is almost certainly secondary FSGS. So complications are complications of nephrotic syndrome, plus end-stage kidney disease. And the management, again, conservative, but most of the time they need treatment with steroids, as for idiopathic or primary FSGS. The response rate is not as good as minimal change disease. You probably hear that as we go forward. I think there's a move towards something broad term called podocytopathy. Podocytopathy rather than FSGS and minimal change, because many people do this is just one disease. It's a spectrum of inflammation at one end, full FSGS at the other end. Take the podocytes, treatment is the same, steroids, but this one better, it's not. And even other treatment potentially not dissimilar, just a lot more FSGS, and their prognosis is not as good. So minimal change disease, although we see pediatrics, still common in younger adults, and even in older patients, I think it's still the second cause of nephrotic syndrome after membranous nephropathy, white population. So it's a good news compared to others. If I find minimal change disease, well, I can tell you this shouldn't cause kidney failure. And they tend to respond to steroids. Many of them will have relapsing or remitting disease, so they may have a few causes of steroids. If they need recurrent treatment, we tend to do the second line. Some phosphomycin, people and children, they tend to use cyclosporin. So their prognosis is generally good. They do respond to steroids. Again, look for associations. Lymphoma is an interesting one. Don't routinely look for it, but we do see it sometimes associated with lymphoma. So diagnosis, the biopsy will look normal on light microscopy. It will likely be so infection and VTE and AKI, if you use that, there's complications. Why would
They lose immunoglobulins within the urine.
So they do lose immunoglobulins among many things. Mainly for this involved. They also can factors. AKI is not common as a result of the disease, but sometimes because we're trying hard to then. An interesting talk recently about we use rituximab sometimes for these patients. Very rarely. But in general, we use rituximab for other conditions like membrane nephropathy as our third line treatment. And there is concern about the nephropathy, they can actually lose the rituximab in the urine.
Oh.
So you have to adjust for that. So you have to think about, well, actually, this is really bad for the urine. You have to give them a bit more rituximab because it is going to go in the urine. Another interesting one I've come across recently, the question about whether they lose serum ACE when you test for sarcoids. Yes, so many things you have to think about on the nephrotic. Is this abnormal because they're nephrotic, or is this normal because they're nephrotic? They're losing it. I can't find it.
Yeah. Then does it make sense to test urine for it?
Yes, that's true. So if you can't find it, maybe you should test the urine for it. Because we had an interesting case recently with we think they've got sarcoid, and sarcoid can cause secondary membrane nephropathy. But the serum ACE was normal. Somebody just pointed out when actually probably losing it anyway in the urine. That's why you can't find it. So treatment is prednisolone, cyclophosphamide being second line treatment, and then cyclosporine or tacrolimus be our third line. These are all real cases, by the way.
Any, he's asymptomatic right now, but has he had recently been well, recent infections, any medications, including over the counter, family history?
Yeah, there are not common, but there are certain conditions like running families and smoking.
Any history of drug use?
Like really must be relevant because they will have it. Yes, so secondly. So these habits is asked about drug abuse. Asked about things to kidney disease to very disease. Asked about hematuria.
So, yeah, urine, urine.
Yeah, so hematuria, it's actually useful to ask. I'd actually use it. I think hematuria ask me.
Pen,
Okay, apart from history, anything else you want to know? It's difficult, but if you think about the list I said earlier, when you see them, you want to assess the renal function. That's systemic. In terms of symptoms, I don't expect him to have symptoms like uremia.
Yeah.
Do they have any signs of fluid retention? Peripheral edema. Blood pressure, you said hypertensive, but you don't mention, so you want to know blood pressure and whether they have any peripheral edema. And of course, if anything from your assessment, anything to suggest vasculitis, you ask about it, but it doesn't sound like a presentation of vasculitis.
Yeah.
This is well and asymptomatic. So you moved on from history and examination. Anything else you want to know?
The investigate quantification of the protein in the urine.
That's right. So you want to know what the urine protein level is, urine PCR or ACR, and you want to know what the kidney function is. I think that's as much as I would be able to get out of the first visit of this patient. But then this were your findings. This way, yeah. Very well. Hypertensive, well, we know that already. Has blood and protein in his urine. It's got a urine PCR of 200. Is not nephrotic. It's high, but not nephrotic. It's fine. Got a normal ultrasound scan. Where does he fit?
More like this kind of.
Yes, so more of the, you can put him as the asymptomatic. It's presenting with you to you because the GP picked up blood and protein.
Yeah.
Doesn't behave like RPGA. This is not nephrotic.
No.
This isn't nephrotic. So it's more of a low chronic GM.
Yeah.
The common cause for that is
IgA.
nephropathy. When I mentioned about hematuria, don't necessarily volunteer that. If you ask a question, they may say, yes, I've passed blood once in my life, twice, last few years, ask when. Have an infection before it, because typically hematuria happens during infection after upper respiratory infection. That's right. So IgA nephropathy, I think that's most likely. If I was going to guess, and I probably guessed from clinic, probably have chronic bronchitis happen over a period of time. From the sports for it, can't really tell you for sure that it is without a biopsy. So it's a common cause, and affects males more than females. Usually they have hematuria after they have an operation. In most cases, it doesn't cause renal failure. It can over a long period of time, and it's very variable. So it can present with RTGN, effectively very rapidly declining kidney function, or similar to this person, but with a more rapid course. So rather than over years, it might happen. So you see, it will present to you in their 20s with advanced kidney disease because of IgA nephropathy. Equally, with diagnosed IgA nephropathy in patients in the 70s who have mild renal impairment. So the same disease but different patients. The diagnosis, these are all clues: hypertension, hematuria, but you need a biopsy to be able to say this is IgA nephropathy. Management, I think this slide will need to change gradually, I think, in the coming years, because there's a lot of treatment options that are coming through. They're not all very effective, but there are options. People are trying at the moment. Every day we have a new trial, a new study about a new agent that we can use in IgA nephropathy. But in general, treatment is conservative. Blood pressure control, and ACE inhibitor, they've got proteinuria. The target blood pressure less than 130. New treatments. Probably know that as nephrologists, we are using a lot of SELT2 inhibitors. So they've had both evidence for using IgA nephropathy.
Proteinuria.
Proteinuria, IgA nephropathy, and use dapagliflozin and its family. Steroids can be used if they have nephrotic syndrome, but with variable results. So there are some studies recently suggest that they're beneficial, but they also increase the risk of infection. So we don't use them routinely, but sometimes we do with nephrotic syndrome. So I've also put on this group MPGN, a condition that we don't see very often. Thankfully, we don't see it very often because the primary form of it, we don't really have a lot of evidence of what to do with it. We can try some steroids, we can try some MMF, have a good prognosis in general. But as I said, it's not common. Typically, then to have low complements, and IgA. If you do your initial blood tests, find low complements, well, this kind of narrows your list of possibilities significantly. So, not many conditions consume complements. So, MPGN would be one of them. Lupus, the other post-infectious GM. That's why it's a very useful test. But not uncommonly, it's secondary. And if it's secondary, then you treat the underlying cause, it gets better. And common thing we look for is hepatitis C. Long list of conditions that can be associated with it. So as the rest, you really can't diagnose it without a kidney biopsy, but it's fine. Help you narrow that list of possibilities. Not dissimilar to IgA, it can present different ways, asymptomatic or nephrotic, nephrotic, IgM, or just basically effectively any of the 6 classes that we've talked about. Yeah, so there's no evidence for a lot of things we do for the primary form of it, but some of them do respond to steroids. We sometimes use I don't like seeing in my clinic because actually don't really know what to do for you. And it's rare, that's why it's not easy to do studies to say, well, we've got evidence now to say we use this drug. So 3. So what is this one?
Post-strength glomerulonephritis.
So you get the idea. That's a very suggestive history, and typically they present. There's a gap. They know it presents between 10 to 20 days after the insult. Only 3.
Cell titer.
Yeah.
Complement levels. Renal biopsy.
Yes, if you need one. I guess needing the renal biopsy. But yeah, ASO titer. If you can go find any other evidence of this infection, might be a one swap. Yeah. Have thought also you want ASO titer foot swap. In most cases, self-limiting. You treat antibiotic, they get better. I'll probably deal with them the same way I deal with the case you mentioned earlier. Okay, this is very highly likely to be positive from PTN. You give you antibiotic and see what happens. That you behave the way you should behave with your virus. Okay. The long list of possibilities, but we tend to see it more with streptococcal infection. But any of these organisms can cause post-infectious GN. I think here in this country, maybe we see it more with endocarditis than throat infection.
Post-infections in endocarditis or during the infection? It's one of the. during the
Yes,
course,
so you could argue it would be either. But yes, post-infectious. Still an immune complex you get it. It's not because of the microthrombi going clogging the kidney. No, it's actually the immune complexes causing post-infectious gene. And again, you can tell by the complements. If you have AKI and endocarditis without complement consumption, look for something else, maybe biopsy the kidney. Complement consumption, this is more post-infectious. Now, this was a case from Doncaster.
Optus said cancer pulmonary hemorrhage.
Yeah.
I'm thinking good pastures, GBM maybe. Not dry. So you were aiming. BP is no. Quite a rapid progression.
Can also be
3
ankylosing.
weeks. Yeah. Like vaginous or upper
Took a week or more diagnosis because he wasn't hospital. Because they're bad. I mean, not very
just don't
obvious.
think of it.
I mean, it's not very obvious. He's a man who has two diagnoses. Assume he's got the bad testing.
It's vaginous.
Yeah, I mean, you can get more massive.
Get to with bronchitis even something.
Sorry?
Bronchitis even can cause
Yeah,
hemoptysis.
so being treated for nasty infection, just pneumonia with bronchitis, that's why he's got his AKI just wasn't getting.
Yeah.
Then if you do that and find the urine dipstick positive, you kind of change everything. Well, you've got something definite. This is not just sepsis.
Yeah.
AKI.
Yeah.
So he has got those proteins, so this isn't sepsis or pre-renal. And again, I must stress that's why if you do urine dipstick test early, you can interest nephrology to say, I think this is something else. I think it's obvious. This sounds like GN. How would you classify this one? Sorry?
It would be symptomatic glomerular.
RPGN.
RPGN, yeah.
Yes. So yeah, RPGN would fit with that. So a period of weeks, very quick progression. What investigation would you ask for?
Urine dip, the ultrasound already done, vasculitic screen,
So specifically, you want.
ANCA C3.
Yeah, I think I would probably ask for compliments, but this sounds more like an ankylosing.
Yes.
Can't be sure. Why? Because things like SLE
Yes.
might present similarly.
Both.
Difference would be if you find low complement, any other standard DNA. Although he's not the age of patient that will present with lupus. So what's your management plan then?
Urgent renal referral.
Okay, that's fine. On one of them. Anything else? That's true. That's definitely what the answer I'm looking for. Need to repair them immediately.
Is plasma for well, I guess when
How can you do that?
So we sent the bloods. We've asked for urgent renal referral, and he's in severe AKI. So he's uvulic.
he doesn't have any indication for dialysis.
He's not
Not you as
What am
well.
I worried more about?
He's not.
Pulmonary plasma exchange, like
Yes,
whether-
I wouldn't ask you to do plasma exchange.
No.
Yes, you could do.
respiratory. Oh, what could we do?
Tranexamic acid. Maybe. If it's heavy hemoptysis.
You can. How can you confirm this is?
CT.
CT.
So CT is helpful.
Yeah.
CT test is helpful.
Yes.
With
Diagnostic.
his AKI.
It's helpful. Sorry?
With his AKI.
Yeah, it was non-contrastic. It will still give you an answer.
Blood, yeah.
Yeah,
It's a
they
blood.
normally
Yeah.
say, but unfortunately, if you leave them, if you say, I think this might be from the heavy answer, we come back to you, yes, this one. Say, I I think this might be infections.
Yeah.
They always may come back to you.
Okay.
Looks like an infection. But it's important to give them the history. If you don't give them any history, it suggests this could be something they won't think about it.
Yes.
You have to give history and say, I'm worried this might be.
Yes.
And what are the tests? Although practically it just doesn't happen. What other tests can you use to confirm?
Hemorrhage. Valve, broncho, something
Bronchoscopy
specific.
might tell you. So if you look through a bronchoscope, you will see some things. Non-invasive tests. Check the gas transfer factor.
TLC, or yes,
that would
to be
be-
elevated.
Mm.
Yeah.
That is just
Yeah.
never
Yeah.
get it.
Few reasons why it might be.
Unsightly. Hemorrhage, yeah.
So yeah, ankylosing vasculitis is due to small vessel vasculitis. Very important to recognize early. Invasive vasculitis, you don't see it very often. Mainly causes then the eye. Eye bleeds with quite difficult. But in serious conditions, it's important to recognize early. For hemorrhage, particularly if you think about it, this is an emergency. Don't last for days. I mean, in his case, that was mild. I don't think it ever caused him any major issue. Managed plasma exchange. In many cases, they do need plasma exchange if they have blood. Can deteriorate very quickly. Giving them oxygen in the water isn't going to help you. Giving them doesn't help them. They need ECMO sometimes just to keep them alive. So it's very difficult to treat when it gets to severe pulmonary hemorrhage. And that's why important to pick it up as opposed to it sounds like fluid. Pulmonary hemorrhage leads to a CT and you need to be transported quickly.
Do they always come with like hemoptysis or?
So there's been a few cases recently we know of because chest more than
Yeah.
then it is tough hemoptysis. That might you then ECMO broken and so it's one of these things. If you think about it, you've got to investigate. Like when this was kind of, if you think about it, you've got to do something about it. Just go and do a CT. The context is usually they may have a history of suggestive vasculitis, but some of them, I mean, I think one of these patients was known to have
Right.
so vasculitis coming short of breath, don't just say I think it's pneumonia.
Yeah.
Look.
Really.
I had a recipe, says IMT1 in Nottingham. Same, like cough, hemoptysis, chest x-ray showed bilateral. We thought severe pneumonia.
Yeah.
Wasn't severe pneumonia. AKI stage 3. He died on the renal ward. He was transferred to the renal ward, got very confused. They put him on oxygen and he was found like by the bed dead. Like, because no one had, it was busy and no one, like, there wasn't staffing
Yeah.
to watch him. And
Oh
he'd been
my
transferred
God.
from rest to renal for plasmapheresis. They put a line in. And
So he got the diagnosis.
so
Yeah.
we got a call in the afternoon from the rheumatologist being like, the PR3 level is like something, please, like, and then so the rest consultant comes, the renal consultant comes, and they transfer this patient, but
It's like even when you ventilate them, it's not easy to ventilate. They're on this factory distance. You can't even maximum oxygen. They can't oxygenate them well.
Yeah.
That's why the earlier you pick them, the better they've got chance of surviving it. So untreated vasculitis is fatal in the majority of cases, but thankfully we have got a lot of treatment options that we can use. Most of them are toxic drugs, but they're better than vasculitis. Okay, so treatment, steroids and rituximab again seem to be coming more and more as an option, as an available option. Still second line, we can't call it first line, but you can use it as first line in selected cases.
So where is the sorry, the renal biopsy in the timeline of events here?
So as soon as possible. But if you're in biopsy, if I had the last one I managed, came to me during Christmas, no way you could have a biopsy till the following Tuesday, kind of 3 days down the line, so you don't get treatment.
Okay.
If they have a biopsy, you may still get something. Unfortunately, the biopsy cannot be the sorry, the steroids.
The treatment, yes, yes.
Yeah, if you give steroids, that might hide some of the features of vasculitis. But it's very clear that if you've got vasculitis patients, you can't get a biopsy. And we don't give them cyclophosphamide. We hide those methylphenidate. Or the steroid is as good as IV.
But if I mean, isn't the biopsy delaying the treatment and they deteriorate rapidly? So
That's
So
why.
if you've got pulmonary hemorrhage, no, definitely not.
yeah, yeah.
No, I'm talking about just AKI.
Okay.
Yeah. So no, pulmonary hemorrhage, you don't delay it.
Yeah, yeah.
Potentially to support your diagnosis, even in the absence of ANCA, if you've got clinical suspicion and definite pulmonary hemorrhage.
Okay.
Try and save their life.
How quickly do we see effect with methylpred?
Sorry?
How quickly do we see like improvement with methylpred?
I think relatively quickly. I'm not talking about kidney function. So you may find that there are symptoms improve first sometimes, depending on how they present to you.
Yeah.
Recovery of kidney function, methylpred is on cyclophosphamide, probably take weeks and sometimes months to get to the best setting. As you should start to see at least stabilization of the kidney function. They get static for a period of time. So plasma exchange is required in case of pulmonary hemorrhage or severe AKI, although the evidence is debatable, but there's still enough evidence to support doing plasma exchange for anybody with creatinine for 500. Again, there are more treatments coming for vasculitis. You may come across patients coming to MAU on a drug called Avacopan. The replacement for steroids, complement inhibitor. For steroid toxicity, you can use it now instead of steroids. So if you see it, you know this is as a replacement for steroids. So if already covered this, that's why you need to act on it quickly, get the CT, let ITU know, even if they're well. But somebody who's got pulmonary hemorrhage might just get worse very quickly.
Yeah.
Pick the last case, okay.
And the very first class of cases you said asymptomatic patients got referred, or because the urinary protein is.
Say the reason for his referral from the GP point of view, probably yes, he seems like somebody who's got findings, but doesn't have symptoms.
So does that something he has interact with the urine dipstick test for blood? Because he has no red blood cells.
Fine, so he doesn't have any red blood cells. But he was referred because he has got blood in his urine.
He's got mild anemia.
Sorry?
Got mild anemia. I don't know what mild. Got mild anemia. Is that anyway?
Mild, necrocytic anemia.
Yeah. So it's not consistent. It's not consistent with you.
Is it?
It's not.
No. I don't know. No.
Yes and no. I
no.
think no is probably right. First, PCR. What's the PCR?
Yeah.
They don't have criteria to start with.
Yeah.
Debatable whether they have hematuria or not.
Yeah.
Because one test say they have, that test says no.
Repeat it again.
Sorry.
Microscopy would be more cute.
Yes, yeah, you probably repeat it, I guess.
Yeah.
Debatable result, I would repeat the microscopy again and just check. Is this just a wrong test or why? Why do they have that? Repeat the diagnostics, repeat the urine microscopy is negative. Why would you get positive?
She said a pigment that's
Pigment, yeah, what pigment?
I guess myoglobinuria will give you a positive, but why would he have myoglobinuria? Something pigment.
metam.
Well, you can get hemolysis, can't you?
Yeah,
Um,
with Dapsone.
Dapsone.
Yeah.
So yes, I think that was the diagnosis eventually. He has got anemia, been taking Dapsone. That's why he got a bit of hemolysis. He has got some dipstick positive test, but no hematuria in red blood cells. He has normal urine ACR and normal kidney function, and normal blood pressure. So think hard to say, is this really GN? Do I need to look elsewhere?
Yeah.
So he didn't have GN. Questions? I think in summary, I think it's useful to try and classify patients in.
Don't try and reach a diagnosis because it's not easy. I can reach a diagnosis in most cases without biopsy. Sometimes I might get a diagnosis with some serological tests, which will take days to come back. So as an initial presentation, just try and put them into which group you belong to. Because that determines urgency and how you manage them when they come to you. RPGN, you know, you have to run, you have to be on, you have to get a proper test. If it sounds more like chronic GM, you have time. Ask for urine PCR and wait for it. Ask for urine test and see this thing to see if this is rapid progress. Short syndrome is not difficult to treat, but you'll be surprised how long sometimes it takes to get sample very deep. So very patient to me. Might be interesting. I can't really prove it without doing the test. And that's what the consultants here says, don't wait for the patient to pass urine, but give them the bottle and say,
Yeah.
the urine sample now.
Get the urine dipstick test or the urine PCR. And then you can't diagnose GN in the absence of blood and protein, which is very helpful, I guess, in many cases.
If you worry about it, the test if it's negative,
It might be TIN.
The ACR and the PCR, when to request each of them?
so request ACR. The lab, unfortunately, they have a cutoff for ACR. So for those protein, this one won't give you a result. If you look at the results on the computer system, they report you up to 400.
Okay.
Anything above 400, you just say above 400.
Okay.
Therefore, you don't get the ratio. But they will automatically report an ACR. In this hospital, it's easy. You only just do random protein.
Yes.
You don't have to specify. But if you ask me, if you go elsewhere, if you GP, request ACR.
I'm asking because of the example that you gave about the multiple myeloma in the ACR, it wouldn't indicate the loss of.
That's right. So
Yeah.
it will not detect that. But not only got to do the right test, it's usually a chance finding. So you do an ACR, a PCR, you find all the protein. That doesn't match you. It's always thing.
Yeah.
It's a big odd.
Yeah.
They've got protein that undetectable by this thing.
In most cases, we would have done a urine test, which then shows protein, and we want to investigate further.
That's right.
And the ACR comes negative, and it makes us wonder.
That's right.
Yeah.
So in case of AKI, I would say not because of this. In general, I ask you in ACI regards to the
Okay.
just as a documentation of where we started. Might be normal. I can document that with normal.
Sorry, it's a busy talk isn't really fit for an hour, but I think we tried our best to do it.
Very useful though.
Very useful. Yes. Thank you.
Any questions?
When do you run your clinic? Dr.
When what?
My
When
clinics.
is his clinic?
I had the luck to attend
I
one.
think
meeting.
everyone did you. So it's confusing because of one do it the same pattern every week. So do first, third, and fifth Fridays.
Yeah.
Second, so it's once a week. It's either Friday or Thursday.
Friday or Thursday. Are you doing one this Friday?
I don't think so. No, actually, no. I've got one on Thursday this week.
Thank you.
Okay, thank you.
Thank you so much.
Sorry, I didn't ask Boston any questions. He got disconnected for most of the talk.
I'm still running.
Did they type some questions?
Yeah. Oh, they're all gone.
Gone.
Oh no.
Okay.
Yes, forgot to switch the camera off.
We have some people attending this online as well.
Yes, yes,
Okay.
they're still here.
Any questions from those who are online? No. Thank you.
Thank you so much.
Thank you.